Okay, thank you, Rob, and nice to have such a good turnout. And I'm happy to share the slides with anybody who wants them. So I will start sharing and. So of course, with the way Teams works, I can now no longer see any of you, and so I'm hoping that maybe Rob, you can just confirm that there is a slide visible that says implementation models and theories.
Yes, we can see the slides,
Right.
and I'll monitor.
Okay. Great. Okay, and as I said, happy for people to have them if you want them. There are a couple of references to. Okay, before we start talking about models and theories in implementation research, I've kind of realized over the years that it's a good idea to talk about models and theories, and I'm a social scientist, I'm a sociologist, so I realize that what I think of as a model or a theory is not always the same thing as people who have a clinical training education or people who have a natural science education. So I thought it was important to talk a little bit about theories and models in social science, because implementation models and theories are social scientific, and they are not like theories in biology or chemistry or maths or anything like that. And I think sometimes that can be a cause of confusion and frustration. So I just a brief overview of some sort of methodological and philosophical issues, and some of you might know or might have experience that I teach philosophy of research, so this is something which is of interest to me, and I strongly believe that it's relevant. Not all of my students agree with me. Okay, so theories and models in social science are not like theories and models in natural science, and I'm afraid I'm very old, and the distinction was between natural and social sciences when I was an undergraduate. So natural sciences are physics, chemistry, biology, maths. Social sciences are sociology, economics, anthropology, politics, and economics and psychology, though they're kind of interesting because they're the more sciencey end of social science, and we can debate. But the important thing is that they are not, social science theories are not testable like natural science theories. They're not refutable, as Karl Popper, the philosopher, would wish, and that they're not even trying to do the same kinds of things. And I think understanding that helps with understanding what implementation models and theories are like, and how we might use them. The first question is, what's the difference between a theory and a model? And indeed, is there a difference in social science? It could be that it's a continuum from theory to model, or it could be that it's a kind of little Venn diagram where there are theories and there are models and they overlap. And unhelpfully, lots of people in the field use the terms theory and model interchangeably, which doesn't make life easy for anybody who's new to it. And I'm probably as guilty of that as anybody. So theory in the social sciences, what can it do? What does it do? It can help us sort things out into groups or into kinds. It can help us sort out things like objects, things like relationships. So those of you who are interested in realist approaches, context, mechanism, outcome, what that is a model of causality. It can help us organize processes or organize structures. The social world is a complicated and a confusing place, and what we're trying to do in implementation research is make sense of it, understand what's going on. Why do some things happen and others don't happen, and what can we do about it? Theories can help us make sense of and organise our data, and implementation research theories are really good at that. And they can help us guide research in worthwhile directions by giving us useful or interesting questions to ask. And certainly in my world, we would expect research questions to be at least theoretically informed and possibly theoretically driven. I find this diagram from a sociologist called Harry Collins, who I'm a big fan of Harry Collins' work, though Harry doesn't really write about healthcare at all. He's I guess in the field of sociology of science, but he works a lot with scientists, and I think comes up against this problem quite a lot in terms of his own research. And he says paper, that we can equally say theory, that a maths or a physics theory is like a house of cards. It's very clear, it's very sharp, but if you take away one element, one card, the whole things fall down. A social science theory, certainly in sociology and I would say implementation research, is much more like a pile of sand. It's not so clear, it's not so sharp. You can take a bit away and it doesn't fall down, but if you take a lot of it away, then yes, it will fall down, it will disappear. So that's just a metaphor, but as Paul Ricoeur, the great French theorist, teaches us, all language is metaphor. So this is a metaphor for thinking about theory in the social sciences, and I would say that implementation science theories are much more like Harry Collins' sociology, that it's not clear and sharp, but equally it doesn't fail just because one element isn't there or we can't find it in the data. And this is a particularly pressing problem for my colleagues in economics. Some of them aspire to be scientific on a natural scientific model, and Danny Roderick, who's a very distinguished economist, and I'm again a big enthusiast for his work, says that that's just not possible in economics. There's not ever going to be one model which works best in all contexts, unlike physics. And what Danny Roderick is suggesting to us that we can't reach a consensus about which model is right, but to figure out which model applies in a given setting. And I'm going to talk more about that with reference to implementation research. And that's a craft. It requires expertise, it requires knowledge, it's skillful, it requires us to learn things, but it's not as predictable or as testable as natural sciences. So for those of you who come from a natural science or a clinical research background, and you're thinking, I find all this kind of stuff a bit vague and a bit doesn't seem to make any predictions, or as my wife, who's very much someone who does systematic reviews and randomized controlled trials, she always describes what I do as fluffy. So if that's how you're feeling, firstly, you're not alone, but secondly, it's in the nature of implementation research, is that it's never going to be science like natural science. And further insight from Danny Roderick, this is why the social world is different. It's man-made, it's infinitely malleable, it's infinitely dynamic, it's changing all the time. And I would certainly say that we create the social world as we go along. I was talking to someone the other day about trying to separate out action, action taken from individuals from their social context. I'd say, it's really hard to do. The action takes place in a context. It's structured and influenced by the context, and that's what makes things possible and not possible. So it's really hard to disentangle them. I should say she was actually quite relieved when I said that, rather than just ruining her research. So we can't make the kind of progress that physicists do, where they replace one model with a better one. We need to expand our library of models, and oh my, we've done that in implementation research. Possibly too much. Okay, if you do nothing else with reference to theory, then read this paper by Per Nilsson, who's a very, very distinguished researcher in the field. It's published in the journal Implementation Science, which is a great place to look and see what's kind of going on in the field and what kind of work people are doing. And I think Per Nilsson does a great job of explaining the difference between theories, models, and frameworks, if indeed there is a difference, and in talking about some of the different theories and the different models and kind of what they're good for, what they're useful for. And one of the comments that Professor Nilsson makes is, there's too many. And people say to me sometimes, shouldn't you be developing a new theory in the field of implementation? I think, well, we've already got enough. We don't need another one. Certainly not devised by me. So what does Nilsson tell us? Theories basically do three things. They can describe or they can guide the process of translating research into practice. He calls them process models. Or they can understand or explain what influences implementation outcomes. Or they can evaluate implementation. Some models, certainly their proponents, might say that they do all three. Sure, that's necessarily the case. People are always enthusiastic about their own model. That's another reason why I probably shouldn't try and devise one. But I think this just kind of helps us to understand some of the things that theories, models, frameworks in implementation research might be doing. Okay, before I move on to talking about the Consolidated Framework for Implementation Research, which is the first framework theory that I'm going to talk about, are there any? Is there anything that somebody hasn't understood? Is there something that wasn't clear or was too difficult that you want me to just kind of pick up and try and clarify? Okay, I'll take that as a no, and I'll dive into the Consolidated Framework for Implementation Research, and the reference is to the updated framework 2022. You might see the earlier one cited in the literature or used, and again, this is not like natural science research where it's absolutely compulsory to use the updated framework. I think it's better. I think it's preferable, but I don't think you are wasting your time if you used version 1. It's not catastrophic. It might not be preferable, but you might have good reasons. Laura Damschroeder and colleagues work at the Veterans Administration healthcare system in the United States, which is it's a very interesting place in US healthcare. The Veterans Administration provides healthcare to veterans of the US military, so that's Army, Navy, Air Force, Marines, and Coast Guard, and to their families. And actually, that's quite a lot of people. The VA looks after something like 10 or 11 million people, so that's as big as the health system in most countries. And actually, it's very much like the National Health Service. It's free. There's no charges anywhere in the system. It's provided nationally. It's provided by the government out of taxation. but only provided to a particular group within the population, and obviously for the US military, I think the existence of the VA is probably an incentive to recruitment for many people. But I sometimes things that are developed in the US healthcare system are not always a great fit for the British NHS, which is very different. Actually, the VA is rather like the NHS in some important ways. So maybe the consolidated framework doesn't have quite so far to travel as some ideas. Consolidated Framework for Implementation Research, CFIR. You'll hear it referred to as CFIR, and so you may hear any of the above. And it's I think the best way of thinking about CFIR is as a kind of aid memoir, as a kind of checklist. It's there to make sure that as an implementation researcher, you've remembered to think about everything that might be important. You've thought about all of the kind of potential issues, factors, the people, the structures, the processes, all of the kinds of things that could be important in explaining implementation or the lack of it of any given intervention. So sometimes people say, well, CFIR is awfully long. There's a lot in it. And I say that, well, that's the idea. It's meant to be comprehensive. And if you're essentially quite forgetful like I am, it does serve that very useful purpose of saying, have you forgotten about this thing? So let's have a look at the various kind of components of it, and just to talk about the kind of things it's pointing us to. It's suggesting that we think about, that we study, that we collect data where we're doing implementation research. So obviously the innovation itself is important. What's the new thing that we're trying to do? And it gives us a group, a list, A to H there, about kind of things that matter or might matter or could matter. Sometimes they're not important, but these often are. And I'll just pick out a couple. Innovation source, who's developed it? We know that with some of the work that we've done on the Flexi project, which I know Rob is involved in, the kind of the credibility and the reputation of the people who've developed it has been important in terms of getting it implemented. What's the evidence base? It's by no means a prerequisite. It's a necessary but not a sufficient condition, as the philosophers say, but people will be interested in the evidence base. But can it be adapted? Can it be tested? Is it really, really complicated? People like things that are simple. I'm involved in a study at the moment where part of the intervention, I guess, is an aspirin. So that has the great virtue of being simple. It's not complicated. It's cheap. Everybody knows what it is. They're 20 pence in Tesco's. The design and the cost. Again, it's suggesting to us, it's not requiring, but these are things that we should think about. We should collect data. And then it says the outer setting, and people always say to me, but Steve, what is the outer setting? And that's always a really hard question to answer. It could be the National Health Service. It could be the NHS and the UK health departments. It could be the global healthcare system. But it's the big picture. It's the wider setting, the wider context for the intervention. Is there an incident? Is there something that has happened that either promotes or inhibits the innovation? What are the attitudes? What are the conditions? What's the network? Who works with who? What are the policies and laws, the professional guidelines? How is it paid for? And oh my, if you thought it was complicated in Britain, Go and have a look at healthcare systems elsewhere in the world if you want to see some extraordinarily complicated ways of doing things. What's the external pressure? I always say, you know, that kind of, no doubt the group who did the recovery trial at Oxford, this is the trial that showed that dexamethasone was effective for patients with severe COVID-19. No doubt they say, implementation, what's so hard? We published a paper in the same day. People all over the world changed what they were doing, started giving dexamethasone to patients. And I invite you to think about what it was, about why that thing was implemented so quickly and globally, when generally, I'm sure you all know, it's a bit harder than that. I hear it is said that for those of you who are concerned about REF, that they had a pretty strong impact case study in the last REF, and yes, the rest of us are not going to do anything like that. The inner setting is the local context for our innovation. Could be a ward, could be a hospital, could be a general practice, could be a primary care network, could be a community service, could be a nursing at home or social care, could be a home care service. Again, you hear me mention Flexi, local authority leisure services, the people who run leisure centre and sports centres, part of the inner setting. So how's it structured? Who works with who? What's the culture? Are people ready to change? Do people want to change? What's the priority? And again, I know that's been an issue with Flexi, is that in some places people say, yeah, this is good, it works, we like it, but it's not a priority just now. What are the incentives? Some of our work on vaccination, it's amazing the difference a £5 voucher makes to people. And mission alignment, again, something that's come up as really important on the Flexi study. Inner and outer setting is about organisations, groups, processes, structures, but we need to think about individuals. Leaders and the people who have formal leadership roles are not the same thing necessarily as the opinion leaders. Who are the people who are helping us implement? Who's on the team? How's it supported? Who's delivering the innovation? And who are the recipients? And it's not necessarily just patients. It may very well be more complicated than that, but we need to think about the people involved. Some individuals can be really influential. And continuing about individuals, think about their characteristics, their capability, their opportunity, their motivation. Motivation is not always great in the UK NHS just now, and the only consolation I can offer you is that many of the things that we'll see, we see in healthcare systems elsewhere in the world. And just the last thing I did before this talk was talk to some people in Taiwan about trying to retain the nursing workforce, because that's an issue for them as well. So there's a lot of things we have in common at the global level. Implementation is a process, and CFIR encourages us to think about that process as well. How did we get the group together? What did we think about the needs and the context? What was our planning? How did we tailor the intervention or the implementation strategy to particular settings, contexts? Maybe they are different. How did we engage people? Did we reflect on the process? We have a tendency to charge on to the next thing. And how did we adapt it? And one of the things that I'm struck by more and more is that there's a real tension between fidelity to an intervention and implementability. How far can we tailor something? Can we adapt something to enable it to be implemented? But if we go too far with that process, do we lose what makes the intervention work? I don't think there's a simple answer to that question, and I'm mindful that in my own work is I'm probably relaxed about adapting it, and some of my colleagues are a bit more anxious about adaptations, probably rightly so, because they understand how these interventions work in detail. So that's the Consolidated Framework for Implementation Research. I'm mindful that it's got, a lot of domains, a lot of kind of subdomains, a lot of elements, and I don't think it's complicated. I don't think it's conceptually complicated, but it's got a lot in it because it's trying to be comprehensive. It's trying to say, hey, don't forget about this thing. Don't forget about that thing. Ask some questions about that. Talk to those people as well. It's encouraging us to take a broad view and gain a really rich and deep understanding of implementation, of what's happening and why it's happening, and some of those kinds of questions. I think its great strength is its comprehensiveness, and I think the fact that it's widely used. So you'll find material out there to help you use it, and the CFIR group have a nice website with some helpful material on it. So but I think something that's widely used, that kind of an informal community of practice grows up, so that there are people around to ask, and I use it in my own work, not because I think it does everything or because I think it's the best one, but pragmatically it works well for the kinds of projects that we're trying to do. And I think it's quite accessible. It's people who are new to implementation research can usually make sense of what it's talking about. Okay, let me get a drink. And I'll move on to, sorry, go on.
Sorry, Stephen, sorry, I didn't know. I was going to pop my hand up, but I know you can't see very well. I was just going to ask quickly, for the characteristics subdomain, is that just relating to the researchers, or say, for example, healthcare professionals on the delivery end, or is it also about the target population?
I think it could be all of the above, and it probably depends on what kind of research you're doing and what your intervention is like. It generally, with implementation research, just as a kind of rule of thumb, it's best to start with fairly broad and inclusive definitions of who you're interested in, and then say, oh, this is my usual experience of, oh my God, that's 150 interviews. There's no way we can do that. And then refine, because we don't want to leave people out. And they could be important, and sometimes important in unexpected ways. So yeah, I wish I could give a more precise answer to your question, but I'd kind of encourage you to think widely about who might be of interest, and often, what we'd like to do is tempered by what we've got the money and the time to do, which is rarely as broad as we would like. And I think, again, I'm kind of mindful that Rob was involved in the praised implementation research, where we had a ton of interesting things to study, and with the grant that we had, we were able to do some of them. I think we did a good job with what we had, but we certainly weren't able to do everything. Is there anything else anybody wants to ask at that point? There's rarely hard and fast rules with any of this. So, and again, I'm kind of mindful that depending on your tradition, sometimes that can feel a bit bit strange. I'm always uncomfortably aware that, you know, there is a right way to do a randomized control trial, and that's the end of it. And this isn't really like that. Okay, cool. Normalisation process theory. So, devised by our colleague Carl May, who is originally a sociologist. So I guess I'm, you know, maybe I'm slightly biased in favour of Carl and his work, but it is widely used in implementation research. Certainly in Britain, it's more popular in Britain than it is elsewhere in the world. The reason I talk about two is just because they are two that are widely used. They're two I've used myself, so I less understand them. They're two you might see in the literature, but there are others as well. And I think normalisation process theory, though ultimately it's trying to do the same thing, is a contrast with CFIR, and that doesn't work in quite the same way. I've always said I think NPT is probably conceptually a bit harder to get hold of, but maybe has more analytical, explanatory value. But I'm mindful when I say that Dr. Claire Mann, who's the research fellow on the Rotate programme grant at the moment, disagrees with me and has told me that I am wrong about that one. So you know, again, you may have a different experience with it, but yeah, it's I guess just to try and set it in some kind of concept. So NPT is trying to provide a way of explaining and organising implementation as a problem of practice, and Carl means practice in the sociological sense of things that people do rather than practice in the clinical sense, though obviously the two can be the same thing, and provides us with a way of understanding implementation processes as projects made up of temporary I never know whether to say assemblage in the French fashion or assemblages, which is English and sounds sort of ugly, of agents, people, and social practices. So it's temporary groups of people and things that they do and organisations, and that I think reflects Carl's intellectual background, but I'm happy to talk about that to the sociologists on the call, but the rest of you might find it a bit esoteric. So what does NPT consist of? And again, it has its elements like CFIR, and it points us to think about coherence. How does a complex intervention hang together? How do people define it? Where do they see the boundaries of it? And it's certainly with complex interventions, it's not always straightforward to say it's this thing and it's always the same every time. With my aspirin, maybe, with the rehabilitation, you know, the return to work intervention on Rotate, that's pretty complex. I think that's socially constructed, though I'm mindful people might disagree with me. NPT points us to around the idea of collective action. How do we organise acting together? A complex intervention is going to be enacted by a group of people. Cognitive participation. How do we think about it? How do the people involved, both the practitioners, the patients, the managers, but also researchers, how do they think about it? And Carl rightly points to us that reminds us that this is a reflective process. We all think about the intervention, we have ideas about it, and those ideas change as the process of implementation unfolds. So put very simply, it's about the work. What is the work? And that that is the coherence. What does it consist of? What are we trying to do here? And do people agree about what the thing, the intervention is, and who's involved? And that is rarely as straightforward as we think. With my aspirin, it's a study called Starship. The aspirin is straightforward. The process of screening, which gets people to the aspirin, is much more complicated. Who does the work? Who's involved? Patients, carers, practitioners, probably lots of them. Could be groups or organisations, and us as researchers. We're involved. We participate, and are mindful that people from Plexi will know that this is a kind of methodological issue that we talked about on several occasions. How does the work get done? One of the things that studies of work over the past 80 or 90 years have showed us is that there is how work is imagined, particularly by managers, and then there is how work actually gets accomplished by the people who do the work, and those two are rarely the same thing. And why did the work happen like that? How is a complex intervention monitored by its users? And we can think of the people and the organizations and the intervention itself as having capacity, contribution, potential, and capability. The capacity is the social resources available to the agents, the things that they can do, that they are allowed to do, that they are able to do, that they are permitted to do. What are the resources that they can draw on to make stuff happen? Contribution. That's about what people are doing. How do they participate? What action do they take? What monitoring goes on? What's the potential of the individuals involved? And capability. What's the workability and integration of the implementation object? And I think this is the NPT version of the CFIR notion of adaptability. How does the intervention change through being implemented? It always does. It always changes. It's never implemented in the way we think it will be, or the way they did it in the trial. It just won't happen like that. And this diagram is showing us how those things work together. I won't go through it and read it out. You can look at the you can look at the diagram in your own time, but it's trying to help us understand how capacity, how contribution, and how capability all work together through the social process, the social structure of an implementation. And this diagram presents us with a kind of different take on the same questions. That capacity, capability, and potential are the things that allow and facilitate, make happen contribution. So the capacity that people have, the capability that they and the intervention have, the potential that they have, all added together make the contribution. And again, it's a dynamic, it's an unfolding process. It changes over time. Again, you can't do better than to read the original papers, and I will I point you to those. Again, you're welcome to have the slides and follow those papers up, though equally I think if you Google Karl May and Normalisation Process Theory, that will take you to the work and the man himself. If you ever get the chance to listen to him, he's a very engaging and genuinely entertaining speaker. It's what I aspire to, but don't usually accomplish. But if you see he's on at a conference, I'd recommend getting along, because you will learn something, and he's rarely boring. Okay, So we did CFIR, we did NPT. There's lots of others. I think in the Nielsen paper, there's something like 60. Too many. These are some of the questions I get asked regularly. So I'll spin through those and my answers to them, and then take questions from the floor. What's the best theory? I hope it's obvious now. I don't think there is one. There's the right. It goes straight on to the next question. What's the right theory? It's the right theory for you and for your project and for the kind of implementation research that you're trying to do. Have a look at CFIR and NPT. They could work for you. There might be others that work better. And the best theory, the right theory, is the theory that works for you and for your project. And there's no kind of external referent that you can test it against. How will I know if I've done it correctly? Well, they're sufficiently complex and non-directive that you won't. If you've got something to say about implementation and you can say that to a wider audience of your colleagues, of practitioners, of patients, then it's worked. It's done its job, and it's helping you to make sense of a complex social process and have some hopefully intelligent and useful things to say about it. Do I have to use all of it? And I mentioned the praised implementation study where we didn't have the time and the money to use all of it, so we didn't. And that's fine. It might not be ideal, but it might be all we can do. And the converse of that is you may find that there are issues or something or some aspect of your work that the theories don't seem to talk about. You've got something that doesn't fit, and that's fine. The world is a complicated place, and we're all interested in researching complicated things in complicated contexts. No theory, no matter how comprehensive CFIR or sophisticated NPT, will necessarily have anticipated every conceivable thing that there could be out there in the world. So if you've got something that doesn't fit, then say so. Say, we found this thing. It doesn't really fit with the theories, but here's what we think about it. Here's what we can say. And I think you're making a contribution to the research and to our understanding by telling us about the places where it might be you found something new, something important. So please tell us all about it. I'm going to finish there. Thanks for listening. It looks like we have a few minutes, so I'm happy to take any questions you might have.
Hi, Stephen. Thank you very much for that presentation. Really interesting and informative as ever. And thank you very much. And we've got some questions in the chat. So first of all, one is, I'd invite anyone also to put their hands up if they'd like, as well as putting things in the chat. We've got quite a few here. Be pleased to know.
Right.
So where does program theory and logic models fit in with this? Do they replace or are they adjunctive to this?
I think they're kind of part of the process, and I slightly hesitate because it often, again, it depends so much on the kind of study, but things like logic models and theory of change are often useful when we are planning implementation, because it helps us to uncover some of the assumptions that we're making about, the social world into which we are implementing something. And if you have a logic model, a theory of change, it may very well be helpful to look at it as the project unfolds and say, well, it didn't work out how we expected, did it? It of course it won't. But that doesn't mean you were wrong. It's just the world's an endlessly surprising place. So I think those things are useful, and I'm kind of mindful that they're often required in grant applications, particularly because they won't give you the money unless you've got some sort of notion of how you're going to change things. So it can be a really kind of useful jumping off point for doing implementation research. Okay, I hope that's an adequate answer. Let's keep going.
Thank you. So what is the relationship between the theory of behaviour change wheel and implementation science?
Okay, so theory of the behaviour change wheel is an approach which some people do sort of subsume within implementation research. I think it's a good theory. I think it has some kind of explicative power and value. I think I would say that the kind of its assumptions about behavior and behavior change are fairly psychological and they're fairly individual. So I think it's a good way of understanding individuals and maybe why they do or don't do something or change something in how they behave. I don't think it's so powerful in terms of understanding, the wider social and organizational context. So again, I think it's another sort of horses for courses question. It probably depends on what you're trying to do. And if you have a particular intervention that's predicated on changing the behavior of a particular individual or individuals, it could be a very useful process to use. I'm often concerned with trying to change how the bureaucratic behemoth of the NHS does things, and I'm not sure it's so useful there. And that's not a criticism of it. It's just a case of what it's good for.
We've got another very good question here. So it may be a difficult one to answer, but it's how do you minimise resistance to change? For example, vaccine uptake by the public.
Oh, good one. Well, I'm just been working on vaccine and minimizing resistance to change. If I knew how to minimize resistance to change, I would have a very, very lucrative consultancy advising organizations and governments how to do that. I think we do know something about it, and one of the things that people ask for my advice on this, I'd say, well, it's about understanding who's involved, which things like CFIR can help us to think about, and where they are at present, what they think about things, what they think about what it is you're trying to change, what they think about the intervention, if it is an intervention, what they think about what you're trying to change. And I think this is where co-design, co-development really come into their own. If you co-design things, they're much more likely to be successfully implemented. They're much less likely to be resisted. I'm afraid that most bureaucratic organizations, certainly the NHS, but we all know plenty of others, tend to still operate in a top-down, people in charge make a decision and impose it on the rest of us. And there's 150 years of management research that says that's not a great way of doing things, but we don't seem to be able to make that argument, and that's probably down to me and people like me. I think if you engage people, engage them as they are, not as you would wish them to be. I mean, I think you mentioned vaccination. We found that just telling people that their beliefs were wrong or not scientific or foolish or conspiracy theories didn't seem to be a very effective strategy. And I think some of the work done by our colleague Prue Hobson-West in sociology about talking to people about vaccination is a much more sort of thoughtful and insightful way of dealing with it. And our own work, which is still, we're still trying to write it up, I think kind of confirms many of those things, that there were things that were effective in getting people to take vaccines, but that there wasn't a magic bullet, there wasn't a one size fits all, and sometimes the NHS in particular likes to do things one size fits all, and perhaps doesn't always want to hear that it's really quite complicated. So yeah, hope that helps.
Thank you, Stephen. If I don't ask this one properly, please come in, Joe, and correct me. So it's, do you have an opinion about operationalizing the theories constructs specific to your study prior to data collection? They've been using a combined framework of CFIR and NPT, replacing the 2009 CFIR process domain with the more dynamic aspects covered in NPT, and have found it imperative to having a shared understanding of what we were trying to achieve for each construct, as they can be a bit woolly to understand exactly what we think the definitions mean in our own context. So I think that's about using two different sort of frameworks together, and using that to sort of more understand your implementation setting. So if I'm misinterpreting that, please correct me.
Okay, no, I mean, I don't think there's anything wrong with doing that. I understand your reasons for so doing, and I think you've absolutely picked up on. I think one of the shortcomings of CFIR is it's a bit static, or it kind of moves us into a sort of static kind of thinking. I'm sure Dan Schroeder and colleagues didn't intend that, but that can be what models end up getting us to do, and that you're trying to keep the, as I've understood it, the kind of dynamic unfolding aspects. And I think absolutely you're right, that you know, even within the research team, we don't always agree about what the, you know, the various constructs or elements actually are. And you know, for me as a sociologist, that's kind of unsurprising, because I think that the social world is like that, and it's full of phenomena which are socially constructed and that are contested. But I think if you know, maybe if you come from a different intellectual tradition, that's a slightly stranger idea to get hold of. And again, yeah, I think what I've known from very much echo your experience, that you know, some time spent on just getting agreement amongst the researchers on, yeah, this is what we mean by, this is what we can agree on as a group. Yeah, and I applaud your rigor in taking on what is no doubt being quite a difficult exercise intellectually, and also quite a lot of work. But I think you'll have a better project for it. So, and yeah, we've done that on some other projects with combining things. It does increase the amount of work you have to do, and that's, you know, that's a bad thing. But anyway, enough on that one. Maybe there's another question.
Yes, so the next question is, I'm planning on using population modelling for predicting drug behaviour in the body. What are the advantages and disadvantages of population modelling?
Oh, I think you're asking a question which is outside of my expertise there. I think population modelling is something that comes from, it sounds to me like epidemiology, and I'm just not competent to answer that question. Sorry.
Thank you, Stephen. Have you got time just for one more question?
Yeah.
Is that okay? So obviously, as you identified earlier, there are lots of theories, models, frameworks, and things. Is there a way to see what might work for you beforehand? Because obviously, you're going to invest a lot of time and energy into doing this. And is there a quick trick you can sort of test a small amount of data before you commit fully to a theory, or can you?
Okay, so I think the first thing is read the Per-Nielsen paper, which I suggested, and that will kind of give you a sense of what, you know, that sort of lays out the buffet menu, as it were. You know, it's kind of fine to test it out. I honestly, I think it's a more interpretative process than sometimes the literature would, you know, would suggest. So it might be that if it kind of feels right, then that could well be the right model for you. If you think, yeah, this makes sense to me, this is explaining things, this is helping me discover and helping me think about, then that's probably right. You may have difficulty in persuading other people of that, but I actually think that's not as bad, because there's just no hard and fast rules, no sort of heuristic or algorithm that that we can use to help you choose. And if you do go down the road of realizing that it's not working and you've done a lot of work, I feel for you, because that is painful to go through that. But yeah, and talk to other people, talk to other people who are doing research around implementation, or if their projects have got an implementation component, just ask them, say, how are you doing it? You may very well find that people have got kind of helpful advice, but I'd always be a bit worried, generally worried by anybody who says, this is the right way to do it. I know the one correct way and everything else is, sinful and dangerous. I do not think the universe is like that. So, be open to what other people are saying, but I wouldn't take anyone's view as definitive, certainly not mine.
Thank you, Stephen. That was really interesting. We've got another question here, which might be a nice one to end on. It's, as a sociologist, why are you interested in implementation models and theories?
Okay, good question. Well, I suppose, the kind of pragmatic answer is, I need to eat. I have, a fantastically extravagant lifestyle with things like a child at university, and people will pay me money to do this. The slightly less flippant answer is that, as with most people, I guess it relates to my biography, is before I was an academic, I was an information manager in the NHS, and did some difficult though interesting implementations of information systems in hospital. And that, what I realized was that, oh wow, all that sociology I did as an undergraduate, oh, that's actually pretty relevant here. This stuff is kind of providing an explanation, and to my considerable surprise and delight, not only did I find it helpful, but I was able to explain things that other people found kind of difficult and confusing. So that was great, and that's why I did the PhD that I did, which was kind of combining the two. And having done a PhD that was about implementation and understanding implementation as a social process, that I find the business of healthcare endlessly fascinating. So I guess I enjoy hanging around with the researchers, with the scientists, and with the clinicians, and finding out about what they do and how they see the world. And I'm skeptical about some of it, but it's all kind of it seems like worthwhile and interesting stuff. And yeah, they pay me money, so that's got to be, I'm afraid that's sadly got to be part of our lives. So there's a pragmatic, but there's also a kind of intellectual motivation. And I actually found that ideas that I first came across in lectures by Anthony Giddens, who some of you might have heard of, in 1982, and I realised that for many of you that's before you were born, are actually helpful in explaining practical problems for why don't people want to do this great new service that will make help patients have better lives. So yeah, I guess that's why I do it. I think it's interesting and worthwhile. So yeah, well, it was all a bit philosophical at the end, wasn't it? But yeah, that's why I do it.
Thank you, Stephen. We're just up over time now, so that's been really interesting. And thank you so much for coming along. And also thank you for saying that you'll share the slides with people. I think we can
happy to do that. So, yeah.
Well, thank you very much. And
all right, no trouble. Nice to see you. Thanks for all the questions. Bye.
Thank you, everyone. Goodbye.